Hello, my name is Olivia Adams, and thank you for viewing my presentation for this Module 1 case study. We will get right into this. So this scenario involves an elderly woman who has severe dementia. She is on enteral nutrition through a nasogastric tube. However, she is uncomfortable and wants the tube removed. Her daughter disagrees, saying that her mother will not get the food and fluids she needs if the tube is removed. The patient does not have an advance directive and does not believe in it. To note, an advance directive, such as a living will, is a written or verbal statement regarding how an individual wants medical decisions to be made for them in the event that they become incapacitated and unable to make decisions for themselves. This can be the case for life-threatening physical conditions or mental conditions such as dementia. In an advance directive, a patient may designate another individual to make decisions for them. There is no legal requirement to have an advance directive. However, not having one may result in medical decisions to be designated to a court-appointed guardian, spouse, child, parent, sibling, or other relative or close friend. This implies that the designated decision maker may or may not be aware of the patient's wishes and will most likely act out of good faith. However, whether or not the patient is considered incapacitated is at the discretion of the primary care physician only. So the registered dietitian may communicate with the physician and other members of the patient's care team regarding the situation, but ultimately it is the physician who will decide. So this scenario is an ethical dilemma. With severe dementia, it raises the ethical dilemma surrounding the patient's autonomy primarily. To note, of relevance is the Patient Self-Determination Act of 1990. This act requires hospitals, skilled nursing facilities, home health agencies, hospice programs, and health maintenance organizations to inform patients of their right to make decisions about their medical care, to periodically inquire whether the patient has completed an advance directive and document their wishes, to not discriminate against the person who has an advance directive, to ensure that advance directives are documented and implemented to the extent of state law, and to provide educational programs for staff, patients, and the community on the ethical issues surrounding patient self-determination and advance directives. So even though the registered dietitian is not the healthcare professional responsible for the situation, they may have to assist the physician by consulting on the patient's nutritional status and ability to feed herself without the nasogastric tube. So in this discussion, several of the Academy of Nutrition and Dietetics Code of Ethics principles may apply to this situation. Principle 1 of competence and professional development in practice, or non-maleficence. As previously mentioned, the dietitian should always practice within her scope and collaborate with the interprofessional team. She would demonstrate her in-depth knowledge of food, nutrition, and behavior to advise the physician on whether or not the patient is capable of self-feeding and drinking enough to sustain herself. Her actions would be caring and respectful to the patient and her daughter, taking into account their unique values and circumstances. Principle 2 of integrity in personal and organizational behaviors and practices, or autonomy, is applicable because of the utmost importance that the dietitian provide accurate and truthful information in communication with the patient, her daughter, and physician, and other members of the interprofessional team. It is also incredibly important to protect the patient's autonomy in this situation, even if her mental capacity has not yet been determined. And the third principle of professionalism, or beneficence, is very relevant because the dietitian will play a big role in participating in and contributing to decisions that affect the patient's well-being. She will have to communicate with the interprofessional team and with the patient and her daughter professionally. All facts taken into account, I would first discuss this issue privately with the patient's physician. Because the patient has dementia, the physician may advise on how capable the patient is of making her own decision. The severity of cognitive disability due to dementia can vary greatly. I would then sit down with the patient and her daughter to discuss the best nutrition care plan for the patient. I will mention that specific enteral nutrition guidelines have been established for individuals with dementia by the American Society for Parenteral and Enteral Nutrition, as well as by the Academy of Nutrition and Dietetics. These guidelines are put into place for patients with advanced dementia largely due to dysphagia that can occur with the progression of the disease. Dysphagia can cause difficulty swallowing, resulting in malnutrition and dehydration in dementia patients. Proper oral feeding in combination with enteral nutrition via nasogastric tube can prevent malnutrition. In simple terms, I would explain to the patient and daughter that difficulty swallowing could make her unable to sustain herself in eating and drinking by mouth alone. I will add that total assisted feeding is regarded as the preferred method of feeding unless the individual is too confused to focus on food or liquid. I would explain to both patient and daughter what total assisted feeding involves, which is often a caregiver spoon feeding the patient. I may also suggest comfort feeding, which is giving the patient food or drink for both pleasure and connection. This method involves careful hand feeding, stopping if the individual becomes distressed, or if they're agitated or if they're choking. It involves interaction for mouth care, socialization, and therapeutic touch with the person providing the food. If this option is chosen, it would require a speech language pathologist to assist with food safety, especially regarding textures. If the patient is still unsure of whether she wants an NG tube following the discussion, or she is unable to make a competent decision, she and her daughter can continue to discuss the decision with full awareness of the risks and benefits. In the event that the patient's primary care physician deems the patient incapable of making her own decisions, I would then give my best advice to the patient's daughter as her decision maker. So, my main recommendation for this patient is to choose comfort feeding for the patient's own pleasure of the sensation of chewing and eating food, combined with continued enteral nutrition support as needed to ensure that she is receiving the proper nutrition and fluids that she needs to prevent malnutrition and dehydration. And for the reference list, thank you again very much for viewing my presentation, and I look forward to learning more in this course.